things that I think the general public should know in order to be able to advocate for themselves. So I see some familiar faces in the crowd, and I'm hoping we can have an interactive discussion, okay? So a little bit about me. As Antonio said, this was my aunt and my godmother, my father's sister. And when I was about 13 years old, we found out that she had breast cancer. And we visited her in Nigeria, and at that time, she had a lot of dark areas and open wounds in her skin. And it was just a very shocking image. And when she later died, unfortunately, of breast cancer, I was very much motivated to try and make a difference. And I ended up becoming a radiation oncologist. So what is that? I do not make people glow in the dark. So unfortunately, I have to put that disclaimer. I don't make people glow in the dark. It's actually something a little more like this, whereby people lie on a table and a machine rotates around them and uses x-rays to treat their cancer. So that is what I do for a living, and I love it. So as I said today, I'm going to focus a bit on just 3 main cancers that are most prevalent in our society: breast, lung, and colorectal cancer. And hopefully you can get from this some strategies for the prevention, diagnosis, and treatment of these 3 diseases. So the basics: what is cancer? So there are normal cells in our body, and they reproduce when and where they're needed. And they also self-destruct when they become damaged or they are too old to continue carrying on their normal processes. Cancer develops when cells reproduce continually. They ignore the signals to self-destruct, and they form tumors that can then travel to other parts of the body, disrupting the normal function. So that's basically what cancer is. So the first cancer we're going to touch on is breast cancer, which is the most common cancer amongst women in the United States. And there are going to be approximately 270,000 of these cancers in 2018. The risk factors for breast cancer include increasing age. So 1 in 8 women are going to develop breast cancer, and the older you are, the more likely it is that you may develop breast cancer. Also, if you have a personal history of having had breast cancer or some other diseases associated with too much division of the cells in your breast, one of them is called atypical ductal hyperplasia. You don't have to remember that, but just know that if you have a personal history of breast cancer or non-cancerous breast disease, you're at an increased risk for getting a second cancer or an initial first cancer. Also, if you have a family history of breast cancer, the things that should tip you off are: is there a family member who was 50 years old or younger? That suggests that you may have a genetic risk for breast cancer. Also, if there's a man in your family who had breast cancer is unusual in men. So if someone in your family, a male, had breast cancer, that tips you off that maybe there's something in your family's DNA that is predisposing you to develop breast cancer. Finally, the last 3 are if you've had a personal history of radiation to the breast, and I'm not talking about either the radiation we do nowadays is associated with less than a 0.5% risk of developing cancer. But historically, when people received radiation for Hodgkin's lymphoma, for instance, it was a different kind of radiation, and it also, over the years, as the years increase from the time you had the initial radiation, you have a higher risk of having cancer. So if you got, the older form of radiation, and it's been many years since you developed it, that increases your risk of having breast cancer due to that radiation. Obesity increases the risk for breast cancer, as does alcohol, having too much alcohol intake. So we have to be careful of all of those factors. So what can we do in order to prevent or to catch breast cancer early? One is breast self-exam. People have different ideas about how often you should be doing a breast self-exam or when to start it. I, in general, say that by the time you are, at least 40, or Starting 10 years before your youngest family member develops cancer, you should be doing a self-exam on yourself monthly. So you don't have to do it every week, just once a month, maybe in the shower, maybe you choose the first Monday of every month. Just be dutiful about it. Do a breast self-exam. And in terms of mammograms, again, the recommendations are varied all over the place. The American Cancer Society says you should start at 40, but there were some controversial guidelines put out by the United States Prevention Task Force, USPSTF or something like that. And they said 50, and that you should do it every 2 years. So many people don't quite agree with the recommendation of 50 years old and every 2 years, because we found women who went dutifully for their mammogram every year, and then in between mammograms, something popped up. And we haven't yet been able to tease out what makes one person develop a breast cancer over, the course of 5 years versus within 6 months. So my personal recommendation agrees with the American Cancer Society. Start at 40 for mammograms, or 10 years after your youngest family member developed breast cancer. And I still recommend annual mammograms for women. The other things you can do if you know you have a family history of breast cancer, for instance, some people are tested, their genes are tested, and they find out that they have the BRCA mutation. You can go in and undergo a mastectomy. So mastectomies kind of took off. They call it the Angelina Jolie effect. After some stars came out, they had breast cancer, they had mastectomies. Many people were opting for mastectomies, many of whom did not need it. But if you are a woman who has a family history of breast cancer, it turns out there's a genetic basis for it. You can opt for a mastectomy. That can definitely decrease your risk of developing the cancer. Other things like drugs called selective estrogen receptor modulators. They may go by the name of tamoxifen, raloxifene. Drugs like this have been shown to decrease your risk of breast cancer as long as you have a certain baseline level of risk. So you have to meet certain factors, maybe your family risk, your age. You have to fit the profile to warrant getting these drugs. Because, as we know, for every cause, there's an effect. For every drug, there's a side effect. So you have to make sure that it warrants you taking these drugs to prevent breast cancer. Other things that might be easier to do, exercise. I struggle with it too. I know doctors tell you all the time, go out and exercise. Can I tell you a secret? Probably half of them are exercising, or maybe less. But exercise is very important. I will say that, and do as I do. I'm not just saying it. I also recently kicked my exercise habit into gear. But wake up in the morning, just do something short. You don't have to go out for an hour. People are doing CrossFit, all these different exercise fads. You don't have to do that. Just get up in the morning, even if it's just spending 15 minutes stretching or a 15-minute walk. It's better than nothing, okay? So a little bit of exercise on a daily basis can help decrease your risk of breast cancer. And also it has other health side effects. Mentally, you get the endorphins going, cholesterol, all those other health risks will be helped by you performing exercise. The final one is limit alcohol consumption. So I know everyone, may like a glass of wine at the end of the day. Nothing wrong with a glass of wine, but they have shown that in women, more than, I think about 3, glasses of wine per week is kind of associated with worsened health risks, including a risk for breast cancer. So I would say to be careful. And no cheating. I know people come out with these jumbo glasses of wine. That's not what I'm talking about. Just your usual standard glass of wine. As we all say, everything in moderation. All right, so symptoms. What are some symptoms that people should look out for when it comes to breast cancer? The common symptoms, 1, a lump, Ideally, you would not feel a lump. It's best to catch the cancer when it's small, but still, if you feel a lump, immediately go and see your physician, get it worked up. And the lump can be in the breast, or it can even feel like it's in your armpit, because the breast actually has a tail. Part of it extends into the armpit. So if you feel something in your armpit, don't just, poo-poo it. It could be cancer, so get that checked out. Other things you can notice are an indentation of the breast, or puckering, like a gathering of the skin. Those could be signs of breast cancer as well. Any liquid coming out of the nipples could also be a warning. And any redness or swelling of the chest area should also be investigated. And how will they be investigated? So some of the tests that are done are, one, a mammogram. And this is, here you'll see, can you guys see my pointer?
Yeah.
Okay. Here you'll see a woman going for a mammogram. She's lying down. Frequently people will be standing for these mammograms. If it's an MRI mammogram, you may be lying down. And the breast will be put into between two plates, sandwiched between two plates and gently pressed. No one enjoys this, and I can tell you, I've gone for it myself. This is not the greatest way to do it, but unfortunately we haven't come up with anything that's more effective at present, so this is the way we're doing it. So a mammogram or an MRI of the breast will be performed. Something else that might be done is an ultrasound, and they can also use this ultrasound to kind of get a biopsy, a sample of the tissue, in order to make sure, is it breast cancer or is it something else, okay? All right, when it comes to treatment, what are the treatments that would be recommended for breast cancer? So there are a number of different categories of treatments. Let's first start with surgery. So when it comes to surgery, that's usually maybe the first step in a woman who has early stage breast cancer. And what are the options? One is to undergo a lumpectomy. And what that means is that just the portion of the breast will be removed. So not the entire breast, just the tumor and a rim of normal tissue around the breast will be removed. And that's usually the case if the cancer is quite early. If the cancer is a little bit more advanced, or there's a strong patient preference, you could go for a mastectomy, and that's when the entire breast is removed. But women also have the option to reconstruct. Women or men, have the option to reconstruct the chest area with a plastic surgeon, and you can start the reconstruction process at the time of your surgery. So we've come a long way in that it doesn't have to be disfiguring, it doesn't have to be a dramatic change in your appearance. You can undergo reconstruction. But some women also opt for a mastectomy without reconstruction, and that's also fine. So it's basically based on your preferences, what you proceed with. The next class of treatments is radiation therapy. And usually if you've undergone a lumpectomy, you need to undergo radiation therapy as well. Because in the past, women just had mastectomies done. There was no option for a more conservative treatment. But now with the addition of radiation to lumpectomy, we can control the cancer just as well as if they had a mastectomy done. So radiation therapy may be one of the treatments that you undergo. Another class of treatments is hormonal therapy. And what that involves are those drugs that I mentioned before. Tamoxifen may be one of them. You may also hear names like letrozole being called out. And the point of all these drugs is to decrease any kind of microscopic tumor in your body that may be left behind. They try to decrease the level of estrogen in your body, okay? So they work in different ways, but the overall point is to decrease any microscopic tumors' access to estrogen in your body, because some of the tumors use estrogen to grow, okay? All right, the next class of drugs is chemotherapy. And how is this different from hormonal therapy? Well, chemotherapy are just drugs that are given to you, and their goal is to destroy cells. So they essentially cause cells to die off, and hopefully the cancer cells will be more damaged by the chemotherapy than the normal cells. But hormonal therapy is kind of a more specific treatment. Its main goal is to decrease estrogen levels in your body. chemotherapy kind of travels throughout your body, and that's why it causes some of the side effects. But most people tolerate chemotherapy pretty well, and it has proven to be a very effective treatment for advanced breast cancer that has spread outside of the breast to the nearby lymph nodes or other parts of the body. Another class of drugs, the final class, are called targeted therapies. And you may have heard about this gene called HER2. So we've been looking at different types of breast cancers, and HER2 is one of the genes that a cancer might use to grow. So the tumor may just be using this gene, overproducing this part of the DNA in their body, and it may be helping them to grow. So what we want to do is turn off that part of the DNA, turn off the HER2 gene, and there's a specific drug for that. So if you have been diagnosed with breast cancer, what you want to do is to ask your physician, do I have a cancer that is using estrogen to grow? Is it estrogen receptor positive? Do I have a cancer that is using the gene HER2 to grow? Because if so, you may qualify for a specific drug that has proven to be very effective for treating HER2 positive breast cancers. All right, so that's breast cancer in a nutshell. Questions?
Is there a particular radiologist, I believe?
Radiation oncologist.
Radiation oncologist.
Yes.
I hear about proton beam. I don't know if that's relevant to this particular type of cancer in general. I don't know if you can give a little information.
That is a great question. So the gentleman in the audience is asking about proton beam therapy. And so radiation therapy is essentially when we use, let me go back a little bit. So I showed you this machine, and what it's doing is through this opening in the machine, this machine creates x-rays. And the x-rays come out and they hit the patient's body and travel through the patient to deliver radiation to that specific region. And the way radiation works is by damaging the DNA of the cancer cells so that they can't fix themselves and continue multiplying, so they die off. Normal cells, even though they're hit by the radiation as well, they're better able to fix the damage that the radiation has done and continue multiplying. So another particle that we can use are protons. So essentially hydrogen atoms can be also used for this purpose, to damage the DNA of cancer cells. And the machine looks a little bit different from this, but the idea is the same. You want to hit the cancer cells and cause them to die off. The thing with protons, the cool thing about protons is that once they hit the cancer, that's kind of where they stop. That's where the proton particles stop. They don't continue traveling through your body. With this X-ray kind of radiation, when it hits the cancer here, some of it will continue. Some of the X-rays will continue to go through your body, and that can cause different side effects. The people we care about most about stopping the beam, the proton beam, where it hits, are children. So in many cases, we want the children we don't want the radiation to affect any growing parts of a child. So proton beams have been used a lot, especially in children, because it hits the cancer and then it kind of just stops. It doesn't go on to touch any other parts of the body. But they've kind of taken this idea of protons and the fact that it won't touch other parts of the body, and it has become a selling point for some cancers. They're using it in breast cancers, prostate cancers, anywhere they can use it. But it hasn't necessarily been proven to clinically give you any better care than this X-ray based radiation would. So in in prostate cancer, for instance, it hasn't necessarily been shown to give better outcomes. Who would I recommend for proton therapy? Children, definitely. Someone who's had radiation before. So let's say you had breast cancer and you got radiation to this area already once. I want to make sure that I'm really minimizing where the radiation goes this time around. We usually don't like treating the same part of the body twice. in my field. So anyone who's had radiation twice, who's getting radiation for a second or third time, or someone who is a child, that's where I really think the benefit of protons is. But you can see a lot of people kind of use it as a marketing tool when it may not pan out to make any significant difference. But good question. Yes.
Hi.
Hi.
I'm Sheila, and I'm very fortunate that Dr. Balogun provided me with intraoperative radiation
Yeah.
for a 2.5 millimeter lump that my medical oncologist actually felt because she was screening me to get a reclass in future to treat my severe osteoporosis. So the rest is history. April 2016 we did it. Could you detail what's going on now with your research? And you said you were able to get funding for a special piece of equipment.
Yeah, so thank you, Sheila. You're fantastic. It's been a pleasure. But what Sheila is talking about is there's radiation that can be given externally, like using the machine that I showed you, and then radiation can be given internally. So in select cases of breast cancer patients, people who have tumors that are less than 2 centimeters in size, people who have those estrogen receptor positive tumors, those tend to do better. They're not as aggressive. People who don't have lymph nodes that are positive for radiation, a very focused kind of breast cancer, we can give radiation internally. So what that involves is you go into the operating room, the surgeon will remove the cancer, and then I come in, and with an apparatus that kind of looks like this microphone, I will place the end of the microphone into a small ball, like a metal ball, into the cavity where the tumor used to be. Because that's the area that's most at risk of the cancer coming back, where the cancer already was. So we place a ball in there, and what happens is that it's attached to a machine that generates x-rays. And those x-rays travel through the machine into this ball in the cavity where the tumor was, and they give radiation to that local area. It doesn't go to as large a region as you would if you were giving radiation from the outside. So it's very focused. We're focused on treating the tumor bed. And the equipment that we were able to get, we're one of very few centers in the United States that has a software that can help us visualize where the dose will go prior to the surgery. So we want to make sure that there's a certain dose that's limited to your ribs. We don't want your ribs getting too much radiation because that will cause a high risk for fractures. We don't want your lungs or your heart, if it's on the left side, getting too much radiation. So we're able to visualize exactly where the radiation will go. And it's been very effective. We've actually made a number of interesting discoveries. We were able to also tweak their calculations. And I think that's a really good option for someone who, for instance, you have time constraints. If you're getting radiation from the outside and you have an early breast cancer, it's about 3 weeks of treatment. In some other instances, in some spatial cases, you may be able to get away with 5 treatments, but frequently it's 3 weeks, 5 days a week. That's a long time commitment. If you have locally advanced cancer because there were lymph nodes positive, you are looking at up to 5 to 6 weeks of treatment, no bargaining. So if you're able to, shrink down the radiation to 1 treatment, it can be a big time saver. And I've had people who maybe they live far away, but they wanted to get their care here, or maybe they had a loved one that they're the primary caretaker for. They've had those small localized cancers and qualified for intraoperative radiation. So that's another possibility. Sheila?
I don't have the BRCA gene,
Yes.
but I'm just wondering, there's been a lot of cutting edge research
Mm-hmm.
genetically,
Mm-hmm.
like the lung cancer. I know somebody who is successfully receiving that. Is there any other genetic implication for what we've been discussing with breast cancer? Is anybody doing research on
On different genes that may be besides BRCA.
it? Yeah.
Oh yeah, definitely. There are a lot of people looking at different. So right now, if you go to get tested for maybe having a family history of breast cancer, there are panels of genes that they do because they know that it's beyond BRCA. There are multiple other genes that may predispose to breast cancer. A gene called P53 that's involved in a lot of other cancers. So there are a lot of genes that they look at, okay? But there are also, sometimes you get back your breast cancer test and it says variant of unknown significance. They don't know yet. They don't have enough patients who have this type of mutation. It's not a change that is normal, but they don't know yet if it really predisposes to cancer. So they keep collecting this data, and I'm sure in about 15 years, they'll have more information, and the people who are variant of unknown significance, it will turn out it's nothing, or maybe it is a predisposing factor.
One last question.
Yeah.
What is the efficacy of doing that kind of broad spectrum genetic screening, say, for somebody like me who has had the localized treatments and thus far has been negative going forward with tamoxifen or,
So doing it at this time point, what would be the use for you? I don't think there'd be much use for you right now. If you already got tested once. You said you already got tested once. And I don't think there's any use now. The people who I think it would be highest yield for are people who, you've seen this kind of family history, or you yourself are a 40-year-old woman, maybe you're the first in your family. Anyone who's under 50 and gets breast cancer, a light bulb goes off. We have to be suspicious. So if you've already done the testing, I wouldn't worry about it now, unless, when were you tested? Was it 20 years ago, 30 years ago? I think it was fairly recent it must have been fairly recent, but if it was, a much older version of these tests, 30 years ago or 20 years ago, then you might want to reconsider. But I think in your case, it wouldn't add much. Yes, sir.
So after surgery for local tumor,
yes.
I guess there are two issues. One would be local recurrence, and the other would be distant metastases. Does the radiation treatment really have much of an effect on distant metastases that will appear later on?
I promise I didn't pay him any money. These are fantastic questions. But it does. Radiation treatment can bear on distant metastases. So radiation can be used for not just curative intent, it can help with pain, so palliation. So if someone, let's say, develops a spine metastasis and it's painful, we can offer them radiation, usually in 5 to 10 treatments to take care of that pain. And over 70% of people who receive that have a decrease in their pain. And if you can imagine, walking around in pain is not the way you want to live your life. So I think radiation has been underappreciated in terms of how it can improve quality of life. So sometimes you're taking pain medications, it makes you drowsy or sleepy, or you're taking them and they're just not working. Radiation can intervene at that point to help with the pain without you needing to be drowsy or sleepy or other side effects like constipation, etc. So we can treat that area for pain. In addition, there's also new interest in radiation working together with immunotherapy. Immunotherapy has gotten a lot of interest. So what is immunotherapy? It's essentially medication that's given, and the immune system is there to fight off infection, but it also kind of puts the brakes. It starts fighting off an infection, but before your white blood cells and other immune components start destroying everything in your body, there's a signal in the immune system that says, stop, it's enough. Go back to rest, guys. So immunotherapy kind of takes off the brakes of the immune system, because we know the immune system also helps to fight cancer, because there are people who develop small cancers and then it goes away. What causes that? The immune system has a role to play. So we found in some patients that by combining radiation therapy at a distant site, giving radiation to the distant site can cause the immune system to fight the cancer at other sites as well that didn't receive radiation. So this is we've seen it in up to 20% of lung cancer patients on some trials. So we're trying to see how we can combine radiation with immunotherapy to really stimulate the disease to go away, not just where we treat it, but throughout the body, wherever there may be cancer. So it definitely has a role in distant metastases. All right. Shall we move on to lung cancer? Okay. So when it comes to lung cancer, there are over 230,000 lung cancer cases that are expected this year. And this in the United States is the #1 killer of men and women, unfortunately. There are new cases that are, the number of new cases are declining, but it's still, we haven't yet found, the best therapies to give cures. We've made a lot of progress. There are a lot of new drugs that have come out. We found a lot of mutations that can be targeted. Remember I talked about targeted therapy like that, HER2. So we found a lot of targeted therapies and we're making progress, but it's very important that we pay attention to what we can do to prevent ourselves from getting it in the first place. So some of the risk factors are #1, smoking, right? Smoking is the #1 risk factor. #2, secondhand smoke. So if you were exposed to people who smoked, you're at a risk for developing lung cancer. Air pollution. There was a paper that came out recently that said air pollution is one of the biggest contributors to lung cancer cases that we see nowadays. Radon gas, that you honestly can't control. It's a naturally occurring substance in the ground that then kind of seeps up into our homes. But we know that it is one of the risk factors for lung cancer. And asbestos, so people who worked in shipyards and with brakes, unfortunately they were exposed to asbestos. It used to be in our homes widely, so that is a risk factor for lung cancer as well. So what can we do? Put the power into our hands to try and prevent lung cancers or to catch them early. One is abstain from smoking, #1. Sometimes I feel like I sound like a preacher. My patients might roll their eyes, but I always feel an obligation to ask people, and you can please help in this. If you know a family member, they say that the people, it's not about how many times you try to quit. It's that you consistently try, keep trying and make them set a date. I always ask people, I say, are you willing to stop smoking? On a scale of 1 to 10, tell me how much you're willing. And many people are motivated, but it's the people who set a date, who say, this is the date that I'm going to stop smoking, that frequently are more successful than those who say, yeah, I'll probably do it. So your loved ones, your friends, make them set a date, and you might find that you might be the change that saves their life. E-cigarettes. So people are now smoking these things. E-cigarettes, I've noticed them a lot on the streets. They have all these interesting smells and fruity flavors and things, but there's the jury is still out. We don't know if they're safe. We don't. I think there was some talk about maybe the particles might be smaller and going down further into your lungs. So we don't know yet about e-cigarettes, but if you had a choice right now between smoking cigarettes, cigars versus e-cigarettes, then I guess I would favor e-cigarettes rather than smoking. So also minimize your exposure to secondhand smoke, and also CT scans. Advocate for yourselves. If you know that you are a current or former smoker who's between the ages of 55 to 74, and you quit within the past 15 years, or you're still smoking, you should be getting a CT scan once a year, and they've shown that catches many more cases of cancer, and it also catches them early, and it decreases the risk of dying due to lung cancer. So that should be part of on your radar, even if you've already quit smoking. Yes.
Okay, I know of one way to motivate yourself to stop smoking.
How so?
Not for me. I have a very dear friend.
Mm-hmm.
He managed to save over $500 in 50 days.
Wow.
And so he's buying himself one of these high-tech TVs. And every time we meet at a 12-step meeting,
Uh-huh.
you know, he'll say how many days it is that he stopped smoking.
Yeah.
The other thing, I wonder, I'm surrounded in my apartment building
Mm-hmm.
by a couple of smokers.
Mm-hmm.
What kind of air purifier, if any, would help me to minimize the secondhand smoke?
So,
Because it's also in the hallway, and I'm in an older rent-stabilized building, you know, that came in '68, and there's very little sealing of, you know, doors and all
Yeah.
that stuff. I mean, is there any hope?
so there is hope. I think that the last thing I have here is air filters. And I honestly, I can look into the cost of them. But, you know, I think usually they say HEPA, HEPA, HEPA filters. That might be something you can use for air pollution. I'm not sure exactly, I put the filter on there more as air pollutants. I'm not sure exactly how effective it is against, you know, secondhand smoke. Is there a section of your building that might be non-smoking?
As a matter of fact,
Yeah,
rent-stabilized
yeah,
tenants on
Yeah.
their lease don't have any kind of requirement not to smoke. It's the market rate tenants that could be kicked out.
wow.
And so, you know, I have two stabilized people on either side of me,
Mhm.
and then there's one market rate tenant. And a couple of my stabilized friends go downstairs and away from the building
Yeah,
to smoke, and we are not permitted to have any smoking on our terraces
yeah.
or in any of the areas within the building. But, you know, beyond that, it's a crapshoot.
So it's not allowed, but people are still doing it inside the building.
Yeah.
That's your health. If
But
you
you see,
want,
the
yeah,
stabilized patient, tenants
Yeah.
are permitted.
are permitted
Yeah.
to smoke. So that to me, I mean, sounds like a
It's a
a
catch-22.
petition.
Yeah.
That sounds like a petition, because in hotels, they have non-smoking floors. Why can't they create, you know, a non-smoking floor designated for the building? It's just a thought. It could be something to just petition them about and say, hey, we would like this floor to be non-smoking, just for our health's sake.
Co-ops and condos can do that.
Yeah, you can't do that in the... I would think of other strategies, but that's the only one that comes to mind.
And NYCHA buildings, those that are publicly funded,
Yeah.
they can't smoke.
All right, so when it comes to lung cancer, what are things that you should look out for? Coughing with or without blood. So if you have a persistent cough, a nagging cough, I'm not talking about if you have a fever or you caught a cold, as I have. That's why I sound a little bit nasal. From your grandkids or from your children or whoever, your coworker. Just a nagging cough with or without blood. Also, weight loss is a tip-off. Unexplained weight loss. If you're not intentionally trying to lose the weight and it starts dropping off, follow up with your medical provider. Chest pain. Any chest pain could also be a risk or a tip-off that you have lung cancer. Hoarseness, because sometimes the lung cancer can affect nerves inside your chest that control your voice. So hoarseness could not be emanating from your throat, it might actually be in the lung. And then shortness of breath are other symptoms that might tip you off to lung cancer. But this is not to say if you have any of these symptoms to get panicked, just go in and get it worked up. And how might you get it worked up? A chest x-ray or a CT scan may be required. They would then do a biopsy, and they could also do a bronchoscopy. And this picture shows you the bronchoscopy. It's essentially whereby they take a long, let's call it a wire, and it has a camera at the tip of this wire, and they will thread it through your nose and down your throat into your lungs, or down your airway into your lungs, to just take a look to see where the lung cancer is. And they may also at this time take a piece of the cancer. So what are some of the treatments? Like we talked before with breast cancer, surgery is one of the mainstays for early stage lung cancer. And you might undergo a lobectomy, which is when they take just a piece of the lung, or you might undergo a pneumonectomy, which is when they remove the whole entire lung. Radiation therapy is also used. Usually it comes into play if you have very early stage lung cancer, but for some reason they don't feel you can tolerate the surgery. So early stage patients might undergo focused radiation to the lung cancer. You also use it when the lung cancer has spread to nearby lymph nodes. After undergoing surgery or before undergoing surgery, you might have radiation therapy to that area. Chemotherapy is usually, again, like breast cancer, used for more advanced disease. And targeted therapy is also one of the mainstays. And we found a number of different genes. So some of these genes are called ALK, A-L-K, ROS1, ROS1. Those are some of the primary genes that we found a lot of targeted drugs that work really well for them. Also, immunotherapy is being explored in lung cancer. So just a little bit of information so that if you know someone, you can share it and pass it along. Any questions when it comes to lung cancer? All right, so we'll move on to the last one I was going to talk about, colorectal cancer. And so colorectal cancer, there are 140,000 cases that will probably occur in 2018. Your risk factors include if you have a family history of having polyps or colon or colorectal cancer, because again, there are genes that can be inherited that will increase your risk. So just be on the lookout for that. If you have a personal history of polyps, that's why if you go in for a colonoscopy, they're very careful to remove the polyps or to pay close attention and monitor them. That can increase your risk for colorectal cancer. Inflammatory bowel disease, things like Crohn's disease can increase your risk, so people watch you closely. Obesity can increase your risk. A diet high in processed foods, processed meats, we talk a lot about nitrates. That can increase your risk for colorectal cancer. Smoking, your alcohol intake, and also type 2 diabetes, which is associated with obesity, can increase your risk for colorectal cancer. So I've named all these things, and there must be some things you can do to prevent or to catch it early. Number one, colonoscopy. So I know it's not pleasant, the preparation, everything that you have to do, but it's a must. Beginning at the age of 50, you need to have a colonoscopy, and it should be repeated at least every 10 years. Okay, ideally, you should undergo the colonoscopy. Also, everything in moderation, like we talked about before. Red meats, processed meats, in moderation. Try and eat more fruits and vegetables, because those have been found to counteract the risk factors for colorectal cancer. Physical exercise, do as I do. If you can't get in an hour, do 20 minutes. If you can't do 20 minutes, even 10 minutes per day is better than nothing at all. And also smoking cessation. If you stop smoking, that can definitely significantly reduce your risk, not just for colorectal cancer, but as I mentioned, for lung cancer and also pancreatic, bladder cancers, etc., etc. So what are some of the symptoms that people present with? Number one, rectal bleeding. It may be due to hemorrhoids, but if it continues, if you notice also a change in your stools, Sometimes people notice that their stools have become flatter, or thinner. That should tip you off that there's something going on more than hemorrhoids, more than just an irritation of your bowels. You need to go in and get it checked out. Any weight loss that you were not intentionally attempting to achieve should tip you off as well. So how is it diagnosed? The first thing would be to do a rectal exam in the clinic. That's what your physician would do. They'll also do what is called a fecal occult blood test. Basically, they take a sample of the material in your rectum, they place it on a piece of paper, and they apply something to see if there's blood in there or not. If there is blood, that's a big red flag that maybe there's a rectal cancer. If you've been diagnosed with that, you'll probably end up going for a CT or MRI of your abdomen and your pelvis. And then they also want to take a sample during the colonoscopy of the area that looks suspicious. I put this picture up here because they've actually put out tests where you can do it at home. You can check yourself if you have blood in your stools. So maybe you can pick these up if you are suspecting that you're having symptoms that are abnormal, but make sure to discuss the results with a healthcare provider, okay? And in terms of treatment, it's the same class of treatment strategies as all the others that we talked about. First, there's surgery. They could do a colectomy, which is a removal of your colon, or they might just take out the bottom part of your colon. Radiation therapy also has a role to play in more advanced disease, as does chemotherapy. And then there are also targeted therapies and immunotherapy that they can use in colorectal cancer. So that's all I wanted to share with you today regarding these different cancers. If you have any questions, I'm happy to stay. Yes, we have